Well, the three of us are healthcare people, so we're here to talk about what's happening at the health system level to move person-centered care forward. My name is Brad Stewart. I'm Chief Medical Officer at CTAC, physician times 40 some odd years, many of those in palliative care. And I have experience with starting programs like some of the ones we're going to talk about here, and many of them have been very successful. I just want to start with a quick story. Everybody's got stories, especially once your hair is this color, you almost certainly have a story. My mother, about 10 years ago, was in her mid-80s. And she, although she was blind all her life, she was very healthy until she began to have spells of sleepiness that just came out of nowhere, and they got worse and worse. She had sort of a workup, not the big academic one, but I had actually spoken with her about her preferences, and I felt eminently qualified to be her proxy, to speak for her, since, I mean, after all, I had all these years of experience as a physician and doing palliative care and hospice. So one day, she just didn't wake up at all. And about 2 days into it, I went to her bedside and put my hand on her shoulder. She hadn't said a word in 2 days. I said, Mom, you know, maybe it's time to go to the hospital. And for the first time in over 48 hours, she opened her eyes, sat bolt upright, and said, "Oh God, no." And that surprised me. And the reason it surprised me because in my doctor mind, she hadn't even been worked up yet. We didn't really even know what was going on with her, but she made it so clear what her preferences were that I had to take her seriously, and it's not what I would have guessed that she would have said, and it wasn't necessarily what I would have decided for her as a doctor. But I said to the folks around, we've got to listen to this. She clearly doesn't want to go back and have more things done to her. And so we honored her wishes, and she did not go back to the hospital and died very peacefully about a week later. The story, I think, isn't just a personal one. It illustrates how challenging it is, even when you have a conversation, to follow the conversation along so that you make sure that the person's preferences and the care that they wind up receiving stay in alignment. That's not so simple when all you have is a document signed a few months ago. So some of us have been after creating systems that actually follow people along as they progress through their as their illness becomes more and more advanced, so that we can know on a real-time basis what their preferences are. Not just their care preferences that we doctors want to know about, but their personal preferences that actually drive the kind of care that they want. So we're here today to hear from some experts on this, and I'll let them introduce themselves just very briefly. Vicki's right down the street, Mass General, long-term palliative care colleague, and Susie Johnson is from my home state of California down south at Sharp Health System, where she and colleagues have developed a way of following people outside the hospital as well. So maybe, Vicki, we can start with you.
Sure, I'd be happy to. Thank you so much. This is such a great showing, and to Bill and CTAC for really sort of, I think, upping the game in this conversation, which is certainly needed. So I'm a palliative care doc. I've been doing it for about 16 years. I'm the division chief for palliative care at MGH, and I co-direct the Harvard Center for Palliative Care. Plus, I work on strategy for our partners' health system related to palliative care. And you know, I always say when I walk into a patient's room, my job is to help patients with serious illness live as well as they can for as long as they can, and in keeping with what's important to them, right? It's about being able to help them match their medical treatment to their goals and values. And unfortunately, there are never going to be enough palliative care clinicians to go around. So we've got to figure out how to enable systems and providers and patients and families to be able to advocate and make this care happen. As Bill was saying earlier, it's pretty clear from the literature what patients want, right? They don't want to be in pain. They don't want to be a burden to their loved ones. They want to achieve a sense of control. And one thing that I think is really important is patients say to me, Vicki, if you think I'm living, help me do that living part. But if you actually think I'm dying, don't make that dying part go longer, right? And that's an issue in our health systems that we actually, as providers and as health systems, with ever expanding options and technologies, don't do a very good job, right? And also as clinicians, Nicholas Christakis taught us that physicians overestimate patient survival by about a factor of 5, which is shocking to lots of people, but if you think about it, it makes a ton of sense, right? I care about my patients. I want to believe in the things I'm doing. So as it turns out, we need systems and policies to help us be able to identify which patients have got a high risk of dying in the next X amount of time and figuring out what those unmet needs are. I think one piece as I've been thinking about policy and health system work and my institution work with this is that it's really important that we get this messaging right. This is not about saving money. This is about doing the right things for patients and helping give them a voice in the medical system. And I think that has to be very grounded in where we start. I always say every day in the US, patients get care, as Bill was saying, that is not going to be helpful to them, that they don't actually want. But we haven't been able to help them understand the likely course of their illness and to help make decisions in a way that's congruent with who they are as people about that medical care. So when I think about the work that we've been trying to do at MGH and on the partners level, we've been really grateful that the IOM published the Dying in America a year ago in November. It had 5 really important recommendations that I think can help drive change at the institution level. One of the recommendations was improving advanced care planning for all patients in a health system with serious illness. Another recommendation was expanding subspecialty palliative care for those who have unmet needs. Another was patient engagement. How do we really have that second-pronged approach, as Harriet was saying, to make sure that there's the coming from the community to be able to be a driver for this care? And also primary palliative care education. There are never going to be enough palliative care clinicians like Brad and I. We are going to have every nurse, doctor, physical therapist, chaplain, social worker practicing at the top of his or her game and being able to recognize that this patient actually is in the last stage of their life, whatever that is, whether that's 6 months or a year or 2 years. I would say when we think about these kinds of components and what's necessary, I would say that one of the first key drivers in this is patient identification. And we need to figure out how to do that as a health system to determine who actually needs these extra services and makes sense to be triggered for these conversations. I would love that every single patient in every single health system has this conversation. I don't know that we can start there because I just think the systems are overwhelmed. So if we can start at least with the patient population who I think has the highest risk, makes sense. We've done some of our work with using the surprise question, asking the clinicians, would you be surprised if this patient died in the next year or 2 years? That can be quite helpful. It's crude. But part of the thing that's tricky about that from a policy perspective is it requires a provider who knows that person well to be able to answer that question. And so I think a really next important step is a predictive model that health systems could use to be able to trigger extra support for these patients, trigger these conversations. There are a whole host of carrots and sticks available to us when we can figure out in a more objective way which patients have unmet needs in this way. I think another piece that has been important to us in thinking about how do we expand, and what if we're going to have, with limited resources, figure out where we're going to invest first. On the partners level, we've done a lot with expanding advanced care planning. Susan Block, Atul Gawande have worked diligently to develop a serious illness conversation guide that has been rolled out at several practices at the Brigham and on the inpatient side, and we're also doing at MGH. Part of what is really critically important about that is we can train anybody to have these conversations, but if we don't trigger and have them know who that person is, it's not going to be successful, right? So we have to help them identify who that person is. Then we have to have the support to be able to trigger those conversations, training the providers and incentivizing them to be able to get this training, and actually to have a documentation in the electronic health record that actually means something and is discoverable. Marion was asking before, what's on your health policy wish list? Oh my goodness, right? Like, wouldn't it be super helpful if the hospitalist who admitted the outpatient could actually see what the patient's goals and values were, and they could say, I never want to go back to the hospital? That would change everything, right? So having that is a critical piece in this system, and it's not just whether they have a MOLST form or a POLST form, it's actually what their goals and values are. I think another piece that we've learned in doing this work with integrating the Serious Illness Conversation Guide is that it is about also having coaching. And part of what we're doing at MGH now is integrating this kind of training, but also having e-consults, we're calling it, or little virtual consults. So when the case manager is seeing the patient and starting this conversation and they run into a question, they can pick up the phone and call. Because part of this is, how do we coach people to be practicing at the top of their game? I don't need to be in every single room, but people do need more than 1 2.5-hour training. I think another thing that we've done a lot of in the partner system that our population health management has helped fund for us is the development of a home-based palliative care program. I think as our population is aging, it is very clear that there are many patients with multiple chronic comorbidities who are too sick to get in to see their primary care doctor. They become a revolving door on the inpatient side, and that is really a problem. So for the last 2 years, we've been working with our care managers in our integrated care management program to actually take nurse practitioners and physicians out into the community to care for these patients. And I think part of what we're seeing is this patient population sort of falls into 3 groups. Folks who really could transition to hospice pretty quickly, but they haven't actually been able to see their providers to have that discussion. Another group who has really significant symptom issues and are looking at really an uncomfortable last year of their life, but they're not appropriate for hospice yet. They're not eligible. Sort of this gap patient population. And then another group for whom they don't have any qualifying diagnosis for hospice, but definitely need that sort of in-home support for a longer-term care. So I think part of what we need to do is think about, how do we help manage these patients in their home, which is where they want to have this care. And finally, the last thing we've been doing, and this is at MGH, we've been very fortunate that Peter Slavin, who's our president, really believes in palliative care. And he believes that this is a way to be able to improve care for patients with serious illness, and that part of what we have to do is invest in every one of the providers in our institution to provide the best possible care. So about 1.5 years ago, we convened a group of about 40 hospital leaders and stakeholders and developed a approach based on the IOM recommendations, and are going to be rolling that out starting in July. And the first piece is a very comprehensive primary palliative care training program that we will do year after year to get everybody's skills where they need to be, and aligning our incentive models, our quality incentive bonuses, to those kinds of trainings. And I think the final piece with this, and as people were talking before, is whether we're doing a program like this and also dealing with another phase in our program is going to be patient engagement, and we're going to start with patient engagement being our employees, making sure that they have had these conversations. We do need to think about evaluation, and I think that's critically important. I think that really what we have to figure out how to measure is goal concordant care. Because the reality is, sometimes patients just can't die at home. Many more can than we, I think, actually what the numbers are now. But I think it isn't going to serve us if we are actually pushing that to be the metric. So I think finding ways to look at other patient-reported outcomes, length of stay on hospice, that is the gold standard for end-of-life care, so being able to do that, as well as finding really facile ways to measure goal-concordant care. And then I think just finally, I can't emphasize the messaging enough. This is too important. What we are doing here is too important, and everybody in this room has got to have the messaging down. We can't have this be derailed again. This is about doing the right thing for patients and empowering them to get the care that they actually want. And I think there's real opportunity to do some really great things.
Thank you. So that's the down the street approach. I just want to throw a couple of numbers out to kind of illustrate, coming from the medical system, here's how it goes in the United States right now. Medicare spending, all Medicare spending peaks at the patient age of 96 years old. That was in Health Affairs a year and a half ago. Older and older people, we are just providing more and more aggressive care. About 8%, give or take, of all Medicare spending. We know that about a quarter of Medicare dollars are spent in the last year of patients' lives. About a third of that is spent in the last month of Medicare beneficiaries' lives, 80% of that in the hospital. Those are just numbers that describe the care that we are currently providing. And as a doctor, I can tell you, we don't think about it. We just do it. We feel that we are providing care. However, some of us have gone out and created programs like you'll hear about now that get out and get with people before they become patients. And I just want to really emphasize how important we think that is. We have a clinical model at CTAC that we're developing and implementing around the country at various health systems, health plans to begin to do this. One of the programs that's really informed how we're doing that is from SHARP. And it comes out of, I believe, SHARP Hospice.
It does.
So, Susie, maybe you can describe how this came out of hospice, which is the person-centered way of providing care to people who are very ill right now. And what your program is able to accomplish. And then we'd like to open it up to questions after that.
Well, thank you. I must acknowledge Dr. Dan Hofer right here in the audience. He's the brain power behind the medical evidence-based part of the program, and that's really critical in developing a program, is bringing the physician leadership in along with the nursing and business acumen. And I think that's one way that made our program successful rather quickly. Just a little bit about Sharp Healthcare to put it in context. We're the largest integrated delivery system in San Diego, of about 18,000 employees, 7 hospitals, the whole care continuum. And we have a lot of experience in full risk business. So with our acumen with managing the dollar, we had an opportunity, Dan and I did, to say, hey, what problem are we trying to solve from the hospice perspective with what we know in patients, the repeat hospitalizations and coming in and out. And we look at these heart failure patients and say, this is so obvious to us. Why are we fighting a system that keeps encouraging people to come into the hospital? So we started talking about, well, how about the never event? How about never go to the hospital? How about never see the inside of an emergency room? What would that look like? And that was a very bold statement to make to hospital CEOs and CFOs, I'll tell you that, in about 2005. We said, hey, what about the never event? And they just were mortified that we would even think that way. And then Dan Hofer took it a step further and made a statement about, well, imagine a healthcare system that's so mindful, so skillful, and so proactive that a patient's care over a lifetime is managed in such a way that they never see the inside of a hospital if it's unnecessary, unwanted, or unplanned. Now, what would that look like, and how do we create it? And then I'm going to give Dr. Stewart some credit because of the work that he did with Sutter. We really were able to take a lot of his early work and AIM and create our own model, and really looked at 4 pillars. And the first pillar is, let's go to where the patient is. Let's go where the person is. Let's not make them come to when they're broken, come to where we fix you. Let's go to them. So in-home consultation. The second pillar is evidence-based prognostication. At what point would a person start using the emergency room and/or hospital for decompensation care? Where's the sweet spot? Usually about a year out, 18 months out, maybe 2 years out prior to death. That's the serious illness trajectory. The third pillar, caregiver support. Why caregiver support? Because of the economic burden that people feel and experience the more they're going in and out of the hospital. Support means also providing caregivers the resources and the tools they need in order to manage their loved one at home well. And the fourth pillar, advanced care planning and/or goals of care conversation. And from those 4 pillars, which were all evidence-based, well written in the literature, we created a case management program that includes a registered nurse, a social worker, spiritual care support, and the chief medical officer for palliative care, which is Dr. Dan Hofer, as the care team. And our patients, or people who are in our program, continue under the care of their primary care physician and/or specialist. And we said, you can have everything care. We're not taking anything away from you while you have this advanced illness management program. You still see primary care. You still see your specialist. You can still have everything you want, and we're going to provide you concurrent palliative aggressive care in the home environment. Well, what do you find when you tell people you can have everything you want? Guess what? They're not so inclined to get everything that they think they want, because you start talking to them and helping them reframe their care within the context of their preferences, values, and goals. So when we started doing that, we quickly found out that when we started talking to people and normalized the normal progression of the disease process in the context of their environment, they began to forego things that they think they wanted in terms of technology, and they began a different kind of aggressive case management care. And through that model, we really looked at, it's very prescriptive. We look at their medications, education around lifestyle. We match their lifestyle with the care that they need. In other words, we don't go in and we're not paternalistic. We don't say you can't do this or you have to do that. We say, tell us how you live. And then we're going to work to create a plan that works within the context of how you live. So we stop creating judgment on people. Another great opportunity for compliance, especially around medication management. And then we handhold them for about 6 weeks in this active phase, and then we put them into a maintenance phase of biweekly telephone contact and a home visit once a month or more often if necessary. And as their health begins to decline, we increase our services again to the point where they're ready to come on to hospice. So we're not letting go of them. From the time they come in our program, we have them. Now, if for some reason they really get well, we move them back into the medical group case management. That's a piece I didn't mention early, but we partner with our medical groups. These are Medicare Advantage patients. We have full risk responsibility for them. So we can move a patient on the continuum. They can come from case management to our transitions program to hospice. They can go hospice, transitions, case management. We're coordinating our care very tightly, and through an electronic health record, we're able to share information and that sort of thing. So the results of our program really have been quite robust in that 90% of the patients who come on our program actually do come into hospice. We are a disease-specific program, so back to the evidence-based prognostication, we focus on heart failure, COPD, advanced stage dementia, advanced stage cancer, and geriatric frailty. And we can see by diagnosis the average length of stay on our transitions program by diagnosis. For cancer, it's about 5 months. Just on the transitions program. For the other diseases, it's a little over 7 months. 90% of those patients are coming on to hospice. They don't see the inside of a hospital ever or an emergency room. We have great satisfaction, family satisfaction, patient satisfaction, physician satisfaction, health provider satisfaction, and we feel like we've really hit a sweet spot with being able to manage people who have serious, advancing chronic illness. We are, if you want to talk on the economic side of it, we are very fiscally responsible and good stewards of our resources. We are saving the system about $26,000 per patient who's referred to us. That is not what we look at first. What we're really looking at first is how do we improve quality of life for people while they're living through the completion of their life. And we're doing a lot of other things in SHARP that I'd just like to briefly mention that are tying all of our community-based programs into the hospital. So hospital-centric culture, which SHARP is also still hospital-centric and will be for a while, I'm afraid to say. We're really working on shifting the attitude in the hospital setting around what a person looks like with advanced illness and what their risk is for mortality within a year or two. So advanced care planning, POLST, we've got a system. We have our advanced care planning and our POLST and our electronic health record. We're now measuring patients at the time of discharge, either by live discharges, all discharges, alive and by for death. Did they have an advance directive? What percentage of patients have an advance directive and or POLST on the record? We can use that data now to shame the system into understanding that what person-centered care means is that we better start asking them what's important, and then we need to measure how well we're going again, how well we're doing that. So it's very exciting that we can actually measure on the inpatient side and on the medical group side the percentage of patients who have an advanced care plan and how well we're doing. A lot of other things. We've got an employee initiative going on, 18,000 strong, making part of our employee wellness program, a program for advanced care planning that we call Lead by Example. And we're going department by department right now. It's just a very robust program. So we're doing a lot of things to address what's being discussed here in real life time. And we continue to learn a lot, and we are really excited about the future.
Thank you, Susie. So we're hearing about a couple of approaches that actually kind of are beginning to steer the ship. It's a big ship, but steer the ship in a different direction and really provide person-centered care out where people live. Now maybe it's time to open it up a little bit. This is kind of the clinical side of things. I'd like to, Dan, I want to ask you a question. Dan Hofer founded the program. Dan and I we have a saying in the field for people who start programs, it's pioneers take the arrows. So I would like to call a fellow pioneer up, Dan. And Dan has policy experience as well as inside the healthcare system. So looking at these new programs, what are the questions we ought to be asking about how, what's the interface between where we're going inside the system and with policy?
So thank you, Brad. I appreciate that. First of all, I have to take some arrows out of my back before we talk. So the answer is that for us, where we're coming from, and the question I was asking from the medical side of the equation that we were creating at SHARP, and I would say the first thing everybody should do is know who your good partners are, find the right partners. So from the medical side, I still work as a family physician. I see patients every day in my office. And there is a fantastic gap in Medicare. It's a chasm that we don't ever talk about. And that's that point when a patient is sitting in a doctor's office, a specialist's office, a primary care physician's office. We know we've done everything we're supposed to for their chronic medical illness, their heart failure, their COPD, their dementia. It does not matter, you name a chronic disease. But we send them home, having given them great advice. But under the Medicare fee-for-service model of care, you can't do anything for them, even though you know in your heart they're more likely to end up in the hospital than to make it back to the next visit. And why is that? Because they don't have a Medicare Part A skilled need yet. They haven't broken. Medicare is based on waiting for things to break to fix them. In all of the new models of healthcare, and Medicare Advantage is only one of them, all of the new models are efficiency models. How can we manage these patients proactively? We can now do something in the SHARP system so that the patient doesn't have to suffer even once through a drowning, once through a suffocation, once through a delirium episode. We give them a third choice. And that third choice isn't manage yourself at home on your own or call 911. But we will go in and partner with them to capture illness early so that we ameliorate or eliminate suffering in these patients while improving the discussion about what the inevitable consequences of the natural progression of their chronic illness. It's not curative care. We need to be really careful when we say that phrase. But the natural progression of their chronic illness holds for them. In doing so, we have improved health care, and we have lowered the cost of care. So I think some people in this room know that Medicare becomes insolvent in 10 years. We will probably, most of us, still be around. I hope we still are. But that's not a minor issue, and I would hope that people would pick up on the economic piece. One of the things I worked was as a utilization manager for 20 years. And I listened to our colleagues from Massachusetts talk about the good medical care they gave. But they forgot to tell you that that was at the expense of parks and recreation, public health, cost of higher education. You can go on to the Massachusetts policy and management state guidelines to see where their distributions of dollars are going, and they're all going down in these other areas where it's going up in healthcare. In the state of California, we raised the tobacco tax, except for one problem. When we raised the tobacco tax, people quit smoking, and they quit smoking so much that those taxes were collected to pay for S-chip, breast cancer research, funding to help people quit smoking, and we shot ourselves in the foot. So we have to be really a little bit smarter and have some sort of fiduciary ethics and better stewardship. I love the word stewardship to the healthcare industry that we're taking care of, because we're not doing a really good job right now. In fact, by doing this type of care, not only do we lower the economic burden, but we provide the type of care that patients want. And we've alluded to this earlier by many of the earlier speakers. We in SHARP are bringing care to patients. You don't need to know whether they have a car, because we will bring care to the patients. We're not bringing the patient to care. And so that's where I see where we've come from is kind of a reactive model. And we need to start thinking about all of these new efficiency models that have been over the last three, sorry, I don't want to get into politics, but the last three presidential candidates have all had similar proactive models available to us, and we need to take advantage of them so we can create a new healthcare system. And we need to move away from the hospital-centric, physician-centric model to the patient-centric model. And I think that would create just be a tremendous service to our institution.
So just one brief question
Yes.
with Glenn and Holly here, and and Mark. We've got a 5-year project here. We can maybe take a look at some ideas for some of our future questions that we might want to ask ourselves, and use the resources that we can just reach out and touch. With your utilization quality and policy experience, how would you take what you just suggested, scale it, operationalize it, and finance it so that we don't shoot ourselves in the foot?
Well, it's a great question, because I was an advisor for the American Hospital Association as well, and I showed them what we'd done in SHARP, and half the people in the room had big smiles on their face because they had capitated contracts, and the other people were still on fee-for-service, so they had big frowns. And they said, well, what are we going to do? And the answer is you have to do it slowly. And I think you could start by looking at something like every discharge to a skilled facility, everyone, has to be evaluated as a potential medical error. Unless there is clear documentation in the chart that the patients were fully informed of the inevitable consequences of the true risk of the care that they were receiving. And that mandates a patient-centered discussion about what we're doing to the patient versus waiting for a short-term fix to an acute problem when there are bigger problems waiting for the patient down the road that the silo of the hospital doesn't see because it's outside of their care.
So let me get this straight.
Yeah.
You're talking about referral to long-term care without properly informing the patient as a medical error. Mm-hmm. Meanwhile, in healthcare right now, the problem Medicare has is that post-acute costs are rising at twice the rate of inpatient hospital costs.
Right.
And a lot of that is because of patients that get sent to skilled nursing for rehabilitation.
Right.
Many of whom are so ill that they may not even benefit from it. So
that's a perfect example, because the National Surgical Quality Improvement Program from 2012 and 2016 suggested that both surgeons and anesthesiologists, and I think hospitals should take that burden too, have a responsibility to inform their patients that although we can fix the problem that's before us, it may be at the consequence of your cognitive and functional decline. Those are patient-centered quality metrics. And we don't want to be an emotional and financial burden to the family, because we know that when you're sent to a skilled nursing facility, about a third of those patients will become a custodial patient at a cost of about $100,000 per year to the family. I now manage patients because I walk this way back up into my primary care office. I say, well, this may be the inevitable consequence of you doing that. So I now manage patients that have been told they had to have surgery, and they say, not with that risk. And that's their choice, not my choice. It's their choice. So if we can institute a process that mandates documentation of the true risks of the care that we're providing, the comprehensive risks, the economic risks, the personal risks, the patient-centered risks, that would create some legitimate change.
thank you very much. Careful, that's kind of revolutionary. I don't want to confine this conversation just to us, so please, anyone else that has a comment or a question, please step up. This is something, we're talking about something here that everyone can contribute to the conversation, and we have huge gaps in our insight and knowledge. Amy.
Well, first I want to thank you for a tremendous panel. One thing in terms of the messaging, you didn't say palliative care is the best thing since sliced bread, the best friend of the seriously ill. What you did say is that it helps people to get the care that they want. I guess I would add the reverse side, which is to avoid the care that they don't want. I'm so supportive. A lot of people don't understand what palliative care is. They conflate it with end-of-life care. You know, clearly I'm not at end of life, even though I'm seriously ill, and palliative care has done quite well for me. But I also wonder about the system itself in which we provide palliative care. Providers, clinicians, I guess provider is not the term of art anymore, don't necessarily refer, even if they have palliative care, until their view of, you know, there's nothing more I can do. So there isn't necessarily the right kinds of referral, appropriate referral, proactive referral, you know, what the National Academy of Medicine would say, you know, early in the process to help people understand the course of the disease, everything that you would say. So how do you, in terms of the system of care, help make sure that those referrals actually happen appropriately?
So that's kind of a proactivity or proactive type question. How can we get past the reluctance that physicians often have to condemn people to having nothing done? How do we be proactive on that?
Yeah, I mean, what's been, you know, I'm in a big academic medical center, right? And a big currency is research. And so for us, the way we have, you know, we have an inpatient consultation service that the average daily census is about 60, between 60 to 70, plus we have, you know, a very robust outpatient program. We don't have a referral problem. And how we don't have a referral problem is because a lot of the intervention study we have done has been on early intervention palliative care. And so, you know, we're coming out of our research related to oncology care shows that patients with lung cancer who get palliative care at the time of diagnosis, better quality of life, 50% lower rate of depression, and live nearly 3 years longer. 3 years, oh my goodness, months. Wouldn't it be great if they lived 3 years longer? 3 months. Thank you, Lachlan. The other piece, research we did recently was really integrating palliative care where the goal is cure, right? We just finished a study integrating palliative care for patients undergoing bone marrow transplant, showed a huge improvement in quality of life, decreased PTSD, depression in both the patient and the caregiver. So I think some of this is we need to see ourselves as something other than end-of-life care and be available and seeing where can we be helpful in the patient who's undergoing a transplant, a solid organ transplant, or a bone marrow transplant, and thinking about how can our symptom management and psychosocial support skills that we have be helpful.
Okay, and Susie, I don't want to let you off the hot seat here. How can these newer programs help solve this proactive problem as opposed to waiting for a doctor to figure out that they need to make a referral? How do these programs be more proactive than that?
Well, I find that the referral process, or knowing the sweet spot. So now I'm thinking, I've got my community-based hat on. I'm thinking about medical group case management in particular, where they've got just a lot of patients who are in their chronic care program. So partnering with them and teaching them, whether it's to ask the question, would you be surprised if your member was hospitalized in the next 6 months, using that as a trigger. Using triggers, I think, is really going to be critical. Some scientific methodology to help trigger and minimally a referral. And then we can make a visit, and we can determine what comes next with a care plan. But I think the science behind it really matters. It's that combination of art and science.
Okay. Thank you, Amy. Claire.
Thanks for speaking today. Dr. Jackson, you were talking about the shortage of palliative care providers, and I'm curious if you think that there are any types of payment reform or other system changes that would help to attract more providers to this field and then retain them once they're in it.
It's interesting. I don't know if it's, some of it is attracting. I don't, we say our procedure is the family meeting, right? That's never going to be really well reimbursed. I think some reimbursement changes that are happening on the national level related to advanced care planning, that's certainly helpful. I think in palliative care, my sense is we really have to make sure that everybody is practicing at the top of their game. I think the question, yes, there's a big shortage, but part of that gap is going to be us making sure that all the family practice docs and primary care docs are able to practice as best they can. I think another thing that's happening, our national organization has introduced a bill called the Pachita Bill, which is to increase funding for hospice and palliative care providers. So we need funding to be able to increase those fellowship slots. It's the slot issue is really a big issue, even bigger than the number of folks who are interested in coming to the field.
Thank you.
Okay, and a follow-up question to you, Susie. As a program designer, I'm sure Dan would agree, you have to take this workforce constraint into account. That you just can't clone palliative care people overnight. It's just not possible to do. So I heard you say that in your program you have nurses, social workers, and you have one medical director who's in private practice, so he's clearly not seeing all the patients. How do you turn doctors into quarterbacks so they can work through these teams and kind of amplify the doctor's expertise and time?
So that's an excellent question, and we're challenged by the same workforce issues in terms of palliative medicine trained physicians and clinicians. We use our IDT, so in our program we do an IDT like you would do in hospice.
That's interdisciplinary team meeting.
Interdisciplinary team, and it's very structured, and Dr. Hofer is doing a couple of things in that. One is to review the medication that the patient is on, and working, and of course understanding where the patient is in their disease, providing education to the staff about what's coming next. So we're always in this teaching mode, and when Dr. Hofer says, oh, it's time to get this patient off that medication, he's actually working with the registered nurse who's making the communication to the primary care specialist. So that's how we keep teaching. If the primary doctor has a concern, then Dr. Hofer will speak directly with that physician. But it's intensive, it's labor intensive, but that is the way we feel that we have to continue to develop the workforce in order to avoid the siloization.
But a key point maybe is that you don't have to have doctors and nurse practitioners seeing every single patient. You can work through a team to do that. So policy-wise, what are the constraints around licensing and the other policy and regulatory changes we could make to make these teams legal and easier to field? I think that's a question, again, that we may want to approach as we move forward.
I'd like to address that too a little bit further, Brad. I think it's really clarifying the roles that a team member has would be very helpful. A physician has a particular role, an advanced practice nurse does, a registered nurse does. We can all work within our scope. And as long as we understand our roles, we can be a lot more efficient and not overlapping where we shouldn't and creating inefficiencies.
Okay. And there are roles that nurses, for instance, could do if they weren't hamstrung by, say, home health regulations.
That is
If
correct.
those were changed around a bit. That's not something we want to go into now, but we certainly might want to dip into it in the future.
Thank you.
Claire, thank you. Lachlan. By the way, are we? We're over time. Don't tell me we have to put Lachlan on the back burner again.
So I just want to thanking everybody, starting with Bill Novelli, really with the vision. This is what should happen. But I think the truth is, people have said variants of that for 20 years. It is fabulous, Susie, to hear about your progress and other things, including better care at lower cost. But the elephant in the room question is, how come that hasn't caught fire and taken over the country? I think part of the reason, not the only reason, I think, is financial incentives, and that even a health system that saves $26,000 per person has actors within the system that make a lot of money off of the surgery and the other things like that. So a policy proposal, I'm just going to quote from the 2010 Massachusetts expert panel on end-of-life care that I chaired years ago with Susan Block and others. One of our recommendations, really just people should be cared for the way they want, says that in future healthcare reform, for any patient with a serious advancing illness, we're listening to Dave, chronic condition, quote, payment for medical services requires adequate documentation that they are based on the well-informed wishes of patients or appropriate surrogates, including understanding of life-prolonging and palliative care or hospice alternatives. What that would mean in the future, and I think if we don't do this, we're not serious, it's a policy issue, is that in the future, if one of Dave or Susie's patients with a chronic advanced illness goes to the ICU, has surgery, all of those things, and they weren't informed of home-based palliative or hospice options, you wouldn't pay for it. Why would you pay for something if you didn't know the patient preferred it? But symmetrically, because I'm worried about underutilization in the future, that if somebody was referred to hospice and they weren't informed that there was chemotherapy or other things that might have been life-prolonging, you wouldn't pay for that either. Why would we pay, why do we continue to pay, as Bill had said, when so often every day people are getting hugely expensive things they don't want, that cause suffering, and they aren't even informed of their choices?
Thank you. We are over time. Thank you, one and all. Some cutting-edge ideas here. Much appreciation.